Today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce Dr. Hallett Mathews, Executive Vice President and Chief Medical Officer for Paradigm Spine and moderator of today's program. Dr. Mathews?
Yes, good morning, everyone. Thank you for attending this webinar on some exciting times for spine surgery. I would like to begin the presentation by thanking everybody for attending, and we have a very exciting program with some excellent panelists. I'd like to introduce our panelists, who are John Pelosa, Dr. John Pelosa from Dallas, Texas, Dr. Mike Masaccio, also from Dallas, Texas, Dr. Richard Salib from Minneapolis, Minnesota, and Dr. Glenn Kuiper from Eugene, Oregon. All are extensively involved in outpatient surgery and all have expertise in minimally invasive surgery. So there's a nice blend of technique, evidence, and the use of outpatient surgeries as we go forward with this discussion. A little bit about this process. So Paradigm Spine is sponsoring this event, and this event is based on level 1 PMA approved evidence for coflex interlaminar stabilization. Of course, when surgeons are discussing patients and concepts and trends, their opinions are represented by that discussion, and individual patient care has to be with your own physician. All sunshine laws do apply, and if there's any questions after this discussion, please contact us at Paradigm Spine. So we have a very rigorous agenda. We're going to talk about fusion and non-fusion stabilization. We're going to talk about the market currently in spine surgery, and we're going to talk about ambulatory surgery centers as being an integral part of the new integration of healthcare and the value that ASCs bring to this discussion. And then we're going to talk a little bit about where coflex as an interlaminar device fits into this algorithm of care. And at the end, we'll follow up with questions and answers such that our participants can weigh in as our panelists will continue to be involved through the discussion. So a little bit about Paradigm. Paradigm is a company that was founded based on a technology that was developed in 1992. There have been over 100,000 applications of coflex interlaminar technology worldwide. There are 3 level 1 PMA studies that are in process, either completed or about to be completed on this technology. It's been very successful worldwide, and it's a market leader in every country that it's in. And this is a minimally invasive technology that is perfect for an ambulatory setting. Paradigm is different because of this strategy, because of the evidence that they have, because of their understanding of the regulatory process and understanding of the market trends. And you will see that this study represents the first comparative effectiveness study in spine surgery. And it creates a lot of firsts that we've never seen in spine surgery, and it helps us to understand where we've been and where the market is moving us forward. Let's talk a little bit with our panelists about fusion versus non-fusion stabilization. So Dr. Pelosa, the history of non-fusion stabilization has been checkered. It's often been for degenerative disc disease and not for spinal stenosis, but yet we see our payers really reimbursing for spinal stenosis and not degenerative disc disease. What's been your experience with dynamic stabilization and motion preservation in degenerative disc disease and also for spinal stenosis?
Well, my experience in degenerative is actually quite good. We were co-authors on the Maverick study, and the outcome data for Maverick was quite impressive. And we've now got 5-year follow-up on those. And those who did well continue to develop for years. That was also the experience with ProDisc L, and now there's several different cervical artificial discs. So the concept, so the technology worked. One of the problems was the outcome data with Charité was good. So anyway, motion preservation is something that works pretty effectively in degenerative. Minimally invasive fusions also work well, but it's more effective. Fusions are more effective for spondylolisthesis, scoliosis, and then degenerative study, the last one where we actually stratified. Now, with the motion preservation with stenosis, the experience I have is with the coflex device. We use both the coflex F and then the coflex, standard coflex now. And both were pretty effective. We've seen over a 1-year follow-up, 2-year follow-up, almost 2-year follow-up with our coflex F. But I think the new coflex that was just released in October is actually working quite a bit better. That device is not as stiff, a little bit more flexible, and we see better motion do our digitized. And I used to do a lot of minimally invasive decompressions for spinal stenosis and accepted a little bit more back pain to try to avoid fusion. But now with coflex, I'm a lot more confident in decompression and then stabilizing it with the diameter coflex device. And it really works well with degenerative spondylolisthesis, where that is now my go-to rather than.
Right. So
Can you hear that okay?
John, I think you were breaking in and out a little bit. So
okay.
While we're on this question, Dick Salif, I mean, you've had a lot of experience with rigid stabilization, dynamic stabilization, and then also this concept of moving it to an outpatient surgery with less morbidity, less surgical trauma. I mean, are we at the point now where we can do decompressive surgery and stabilization without rigid fusions? And if so, why isn't this something that's the anchor for our techniques in outpatient surgery?
Well, I think there's no question that with the release and the FDA approval of the coflex implant, and before that, just as John said, the coflex F implant, this brings the possibility of doing outpatient decompression and stabilization for patients, particularly with spinal stenosis, whether or not they have degenerative spondylolisthesis or not, as long as it's not unstable. It works extremely well in my hands, and I think in all the panelists' hands have had the same experience. Whereas the previous devices that were dynamic stabilization, such as there were all the dynamic rods from K2M, DNS's, and all of the pedicle screw-based dynamic rods, I don't think any of those really were very practical for outpatient setting at all because of the there's just a greater degree of discomfort. It's not really possible to do those as minimally invasive procedures.
Right. And a lot of the technologies have been fusion-based versus the concept of appropriate stabilization. I think that's an important distinction. That our technologies for the last 25 years have been mainly fusion approvals and fusion-based static stabilization, and not motion-preserving after degenerative stenosis decompression. So we'll move on, but this is a good start to the discussion, and I think that we have a lot of things to talk about. So enter now spinal stenosis. A U.S. citizen turns 65 every 8 seconds. Okay, 10,000 people retire in the U.S. every single day. There is a baby boomer phenomenon that's occurring, and stenosis is the largest group of musculoskeletal patients that is coming into the system. And of course, we all treat spinal stenosis conservatively, but look at how many patients are in the system. From conservative care to intervention management to the surgery, stenosis is a huge problem right now, and it historically has not been done in outpatient surgery centers. I think, Mike, you're a neurosurgeon. I mean, you're an expert technician. I mean, stenosis affects all parts of the spine. When you see pictures like this, you wonder, how can any device take care of all that? Isn't the surgeon the one that takes care of spinal stenosis?
With the, well, I believe so, and in a lot of ways it's correct, particularly with coflex, and why the coflex helps this patient with stenosis, because you're actually doing your direct decompression. So I think that if you can combine a direct decompression and actually decompress the nerves through your laminectomy approach and then stabilize afterwards, as opposed to depending on the device itself to create an indirect decompression through a false kyphosis or some other lines, I think it's all, all the better. So I think they go hand in hand. I don't know if I diverge a little bit, but one of the true benefits I see with coflex is after you've done your direct decompression, which is a surgery we're all very familiar with and comfortable with, we're then reestablishing that motion segment, and most importantly, or very importantly, maintaining that foraminal height, preventing destabilization, degeneration, reestablishment of stenosis in the future. So I think the surgeon has a lot to do with it. I think the device helps augment that as well. But what's nice is that, again, the direct decompression is what stands apart for me here in this patient, this stenotic patient, and this device. And as it pertains to the outpatient center, it's very simple to do. Your laminectomy is basically the entirety of the procedure, another 5 minutes at the end. Place the device in, you're not increasing the morbidity, operative time, and blood loss. So,
yeah, I totally agree. So is Dr. Kuiper on the phone? Did Glenn get on?
Yes, I'm on.
Glenn, thanks for stopping by. Look at these slides. I mean, these are decompression patients that we all agree need decompression, right, for stenosis. And so stenosis varies with location, intensity, even level by level. I mean, how can a device do this without a surgical decompression? And then how can you decompress this without thinking about load transfer and instability and progressive degenerative disease?
Well, the key is the decompression. You have to do a great decompression, otherwise you're not going to get a great result, and you're not going to take advantage of what the coflex has to offer, which is the stabilization and decreasing back pain. But primarily, you have to get the decompression done, and then prepare your spinous processes and lamina properly to accept the device. And then you can expect to have your back pain go down. You won't have a recurrence. If you have a grade 1 spondylolisthesis, you can get that to reduce and become less than a grade 1, or even go back to 0. And the results that I've had so far are backing up everything that the study purported in the first place.
Right. So I think that's important. And so technically, I think everyone's better now than when pedicle screws and rigid stabilization came into the U.S. I mean, we did bigger incisions, we did more trauma, with more morbidity, but technically we know how to decompress these patients minimally invasively and with less trauma, and it opens up the opportunity to do this in an ambulatory setting. So the question is, why did we always fuse? Is it because we only had one way to stabilize? Or is it because we didn't have data in a prospective level 1 study to support another form of stabilization historically? And as we've gone through this algorithm and looking at the history, we've had one technique, one type of stabilization, and we've historically learned that, and we've historically fused people for that. But I think there's a new generation now of people that are asking the question, do we have to fuse to stabilize? And can we decompress this baby boomer stenosis disease that's hitting us? And can we do that without static stabilization and forcing a fusion algorithm on everyone? So the focus here is on stenosis, and the focus here is on a treatment algorithm that helps patients with the least invasivity. So when you look at this market, if you go out on the floor of a big trade show, there are fusion devices, there are blocking devices, and then there's motion preservation devices. I don't think I've had a patient ever walk into my office asking for a fusion. But we taught people how to accept fusion, and we taught them how to use the bucket on the left, which is the interspinous devices, and we taught the bucket of blocking agents such as Diom and X-Stop. And now we have a new interlaminar technology that's actually loading different bone after the surgeon's done the heavy lifting in a minimally invasive way. So this changes the algorithm of spine surgery being dedicated to inpatient facility, because now we can do motion preservation after decompression in an outpatient facility. So it's a new game. It's a new game. So these devices are clear. They're not all the same. Ambulatory surgery is a perfect venue for stenosis surgery, and we've seen that in the PMA study. So let's move on to where the market's going and what the trends are that we see. So we talked about the prevalence of spinal stenosis. It's really increasing. And we talked about favorable outpatient outcomes in ambulatory surgery centers because you can control the point of contact, you can control the variables, you can collect the data, and you can control the quality. And this market trend is very well established as this big patient surge hits our market. So it's the largest demographic growing in spine surgery. It essentially will double in the next 7 to 8 years. It is essentially being touted as being the savior of all these patients coming through because the outpatient setting will be much more efficient and able to handle spine surgery. And this is the perfect situation with minimal invasivity and stabilization without fusion to do this in an outpatient setting. And with the expansion of outpatient surgery centers across the country and with improved quality, reporting, and outcomes, it becomes the obvious choice for surgeons and for patients to use these optimal systems as their vehicle for getting care. And so this is a huge upside for this technology and for surgeons to gain the efficiency and control through an outpatient setting. So coflex as a technology fits in between a traditional decompression and then a traditional decompression infusion. And so this is the first time we've had the ability to really take mainstream spine surgery into an outpatient setting. And you guys on the panel are the experts in leading the country with regard to that. So let's look at this from a disease spectrum. So John, on the left is stenosis and age-appropriate disease, and on the right is really unstable pathology. How do you look at your patients in your imaging studies and determine who could I do in an outpatient setting versus an inpatient setting?
Well, the first thing is the health of the patient. I mean,
Absolutely.
somebody who's healthy, robust person, you can do that person in a surgery center without too much trouble. We do have backup with a hospital if we need it, but for the most part we haven't. We've had very few readmissions or complications or anything like that. So I think the first thing is the health of the patient. Then the second thing is what their diagnosis is. Almost all minimally invasive techniques through a tube, tubular retractors for just decompressions do pretty well in a surgery center setting. Even the most cervical patients do well in a surgery center setting, even fusions or disc replacements. The coflex device has been very, very good in a surgery center. I mean, most of those people go home the same day. Sometimes we keep them overnight because initially we had some wound issues with hematomas, so we put a drain in everybody. And if it doesn't put out much after about 4 hours, we'll pull the drain and send them home. If we need to keep them overnight, we can do a 23-hour admission in Texas anyway. That's not a problem. And then, so I think for all of those people, and that with the coflex now, that's the majority of the stenosis patients we're seeing. The people that you would probably move it more into the hospital would be the person who has a greater than 1 spondylolisthesis, a pars defect where they're really unstable, the thing that pedicle screws were actually made for. Certainly somebody who has scoliosis with a major curve and coronal and sagittal imbalances that have to be corrected. That's a surgery. That's a hospital patient. But now with the new technology, what's that?
And to that point on the slide, you see the right column, which is the real unstable patient, which is dedicated more to an acute care setting.
Yeah.
So as everybody gets technically better and you have technology that doesn't force a fusion, you have the ability to decompress and stabilize. I want to jump to Glenn. You know, Glenn, I mean, you have a lot of activity in your surgery center in Eugene, Oregon. You see the column that says, you know, acute care setting and the coflex decompression, which is column 4 and column 5 of the grade 1 spondies. Are you able to do those successfully in your surgery center, or are they inpatients for your center?
If the patient's healthy, they're both candidates for the surgery center. We're doing coflex for the grade 1s, and if they're greater than a grade 1, I use MIS technique and do a pedicle screw fusion, and haven't had any trouble with doing those patients as long as they're healthy in the outpatient setting.
So that's really a great tribute to your technical ability, and knowing that if you get the patient expectations to that point through education pre-op and they're healthy patients, then outpatient surgery centers can handle some significant disease if the setting is right and the patient's appropriately selected. So this is a real important concept.
That's right. Even the insurers are catching on to the fact that there isn't a lot of 1 and 2 level surgeries in the neck or in the low back that can't be done in an outpatient setting, and they're also catching on to the savings that they make by having their patients cared for in an outpatient setting.
Correct. Good point. So as we look at the procedural opportunity in the outpatient setting, you see one common denominator, which is to the right, which is pain procedures, stenosis procedures, and minimal access surgical procedures. There's huge opportunity here for outpatient centers to actually start doing these procedures outside of a hospital facility and to gain control of that. So there is a great upside to this, and this technology and level 1 data from 3 PMA sites is huge for that. So let's move on to the value. What does the ASC bring? It brings a lot of things to the table. It brings control. Surgeons regain control over flow, dynamics, actual process, such that the surgeon has a lot more control with the instruments, the way the patient is processed through the system, and the recovery process. And also ASCs can get data quickly. They can look at their own outcomes. They can get the evidence-based medicine for their payers and for their region to be able to support the quality and the cost savings. And you can actually save money compared to the big institutions. So what does that mean? Fusions, if you haven't figured it out, were not on the radar in 1990 as far as total healthcare costs. Spinal fusion has just eclipsed balloon angioplasty as the #1 cost of the hospital system. Okay? This is huge. More than hips, more than knees, spinal fusion is now numero uno. And so payers are pushing back. If you don't have the evidence, if your costs are too high, if the implants are too high, this whole system has to readjust. And the evidence burden is on us to collect the data, show the outcomes, and show the cost savings. And so when you look at open instrumented spinal fusion revision rates to the operating room and failure rates, they're pretty darn high. And that means the costs are high. So how do we improve the system? We create better value through this technology and our minimal access techniques. We improve the effectiveness and the outcomes, and we reduce the cost. Net effect is improved value. Mike, Ms. Asha, you guys have a great surgery center down there. You guys collect data on all this. Are payers interested in contracting for like total cost of care contracting? Where are facilities going with this? And because you have the data, you can actually compete with the big institutions to save money.
You know, Hal, the first part of that, as far as are payers interested in the total cost of care, as you're referring to the package, the presenting for a patient with stenosis to come to a center that can obviously operate at a decreased cost in an acute care setting, and then have the providers be very reliable, same provider, same anesthesia, know the fixed cost of the product, and then a good sense of what your expendables and implants would be. Yeah, I think the contractors are looking for that, and I think most of us are trying to develop that program to go to the different payers and say, well, here's what we can do, and here's how well we do it. And that's where the second part comes in with the data. And I think the data goes above all else. It's not just how cheap you can do it or how cost-effective you can do it, but with what quality and what exceeding level of quality you can do it. I think I don't have to tell the members of the panel or certainly the listeners who are believers in ASC that our quality has been shown repeatedly to be exceeding that of the hospitals by far, unquestionably. So I think those are both very important points, and we are armed with that information at this point to go forward and make those deals or arguments for the payers.
Yeah.
Well, Hal,
so
Hal I would.
Go ahead.
Hal?
Yes.
John Pelosa. We have been frustrated by the payers here in our market because they've been driving a lot of the spine surgery to the hospitals, regardless of what we've shown them. They've visited the center, they've seen it, we have all our outcome data in terms of what we would collect for an FDA trial, but we also all know our costs, and they either try to contract with us as so ridiculously low we can't do the case, so they drive it into the hospital. Now that may be changing. There's a lot of effort to change that dynamic, but a lot of places things are local, and if the hospital systems, if there's one or two hospital systems that can really monopolize a market, they can drive a lot of what the insurers do. Now, we just got something from Colorado, United Healthcare their CEO is actually looking at and talking about taking spine into the ambulatory surgery center. So that's good. I mean, that's a start. We can go there and we can give our our numbers to the insurers to show what we can do. And there is a lot of activity to do bundled package pricing, not only from surgery centers but also from hospitals. So that's happening in markets. And now, with if spine care becomes rationed for whatever reason, that's very powerful. Also, if looking at medical tourism, either in U.S. or from outside U.S., that becomes very, very important. When the patient or a company has to pay for the cost of care because insurance won't, then the whole game changes.
Yeah, well said. And I totally agree that that's a market trend that we're seeing. Just one more comment from Dr. Salib on this slide. So, as we've seen fusion outcomes over the years really kind of languish in the 60s and 70% of outcome improvement. I'm not talking fusion rates. I'm talking about overall patient improvement. That's an effectiveness statement. So our effectiveness has not been so great because our trauma has been high, our morbidity has been high, and I really question whether fusion is the right model for stabilization. And so hence, to increase value in the system, what's happened? You've seen an erosion of price because the costs have to go down to even keep the same value statement going forward. Dick, I'd like you to comment on the effectiveness of fusion over the last couple of decades, really the disconnect between fusion rates and outcomes, and how patient selection and getting the right patient is really the most important value driver of this whole process.
Sure. Well, certainly the effectiveness of fusion is dependent on the patient selection, as all surgeries are. And I think if the degenerative process is limited to one or two segments, fusion can be effective in 75–80% of the patients that you do a fusion on. But your fusion rate is probably closer to 95% in most of the modern fusion studies, and that we would see in our own patients. But so there is a disconnect between the fusion rate and the clinical improvement. But the the other things relate to just return to activities, and I think patients' perception of fusion. I think as well as the insurance company's perception of fusion. The patients have this perception of fusion as if they have one fusion, then they're basically signing up for another fusion, and I think that is not always true. I think the younger the fusion, the younger the patient who has a fusion, the less likely they are to have had it. I saw a patient in my office today who had a two-level fusion 20 years ago, and now they just have a little bit of facet joint degeneration at the level above, and really not even any disc degeneration at that level. But her fusion was done when she was in her 30s. It's a different story if you're talking about fusing this population of patients that we're talking about, the older patient with spinal stenosis. It's pretty unusual to find a patient with spinal stenosis who has perfectly pristine discs at all of the other levels. And I think that the success of a fusion is really dependent upon, how healthy is the rest of the spine? How healthy is the patient? Do they have a genetic predisposition to disc breakdown and all of that sort of thing? So I think that's where the efficacy of spinal fusion really languishes and is hurt a lot. I think if we were more selective in our selection of patient for fusion, then we might do a better job. But I think there's a push for everyone to feel good, and we know that we can get fusion much better than we could 15 or 20 years ago. We're much more successful at getting the bone to grow. I'm not sure we're that much more successful at helping the patients, though.
Yeah, I totally agree. That was well said. That really leads us into kind of the evidence that supports this treatment for stenosis. So when you have a technology that allows for an ASC setting, and most of the cases in the U.S. right now are now being done in outpatient surgery, and in the PMA study you show shorter operating times, less blood loss, less hospitalization, quicker return to activity, less narcotic use, quicker return to work, and you can maintain foraminal height, maintain motion, and not do anything to the adjacent level in an older population, that's really powerful. And I think this is what this evidence is leading us to. So biomechanically what happens with this device is it actually loads on the interlaminar line, it unloads the facet joints, and on flexion and extension it actually compresses and releases. So there's motion preservation with maintenance of foraminal height. And this is a very functionally dynamic load transferring device supporting painful arthritic facets and also maintaining foraminal height. That's like the perfect scenario for an older patient with stenosis. And it's important that we look at that compared to what the alternative is. So here's a patient that randomized to fusion in the US PMA study. And not that all fusions do this, but these are older people. And at 4 years, this patient has a bone-on-bone adjacent level disease because facets in older people, average age 63 in the US, can't take the load transfer that rigid stabilization gives to them, even though their stenosis can improve. So the study is really important to kind of just step back for a second. This is 1 and 2 level spinal stenosis, moderate to severe spinal stenosis with up to grade 1 spondy. And the spondies we're talking about are significant spondies, but not very, very unstable. So the picture on the left is actually the spondy that's included in this study. The picture on the right is a very unstable grade 2 that's not going to do well with coflex. So I think we should define that first. Not all spondies are always candidates for everything. I think Dr. Kuiper said it well, is that his higher grade spondies, he can do minimal access TLIFs in an outpatient surgery setting, and that's the preferred operation of choice. So this study across the U.S. was a level 1 study, prospective randomized control study with 384 patients in it. And it went through a formal FDA PMA process, and it got approved last October of 2012. And it's had its U.S. launch essentially this year. And this is what a PMA looks like. You talk about collecting evidence. This is one copy of it. And when you look at the follow-up rates of all of this information, digitized x-rays, case report forms, this is a monumental effort to do this. And the follow-up rate was absolutely astounding to get this kind of completion and follow-up so we know how these patients did. And when we look at this at the end of the day, we found coflex gave faster relief of symptoms, better long-lasting relief, better patient satisfaction with less blood loss, OR time, time in the hospital, and less downtime. So if the patient's got less downtime, you also have less downtime as a physician performing this procedure. And so the hospital stay is significantly less, narcotics are significantly less, and this really favors an outpatient surgery setting. So Dr. Kuiper, you brought up the concept of higher grade spondies being done inpatient. Have you appreciated that these devices still move? I mean, when we look at the PMA data, these devices are still moving at the index level, whereas fusion doesn't move. And Glenn, I guess the concept is, what changes in older facets if you do fuse them? Look at the blue column, whereas coflex range of motion above is the same, whereas fusion starts to get hypermobile. Is it because these facets are older in 60s and 70s and the patients can't handle that? Or is it because of our techniques better of a coflex insertion than with pedicle screw insertion? Do you have any thoughts on that subject?
Well, once you rigidly fix a segment, then you're putting a stress on the adjacent segment above and below. And you're going to, because that segment has more stress, it's going to wear out faster. And that's why you get the hypermobility. And then you end up, the spine tries to stabilize itself, and therefore you get rapidly progressive lumbar stenosis at those levels and degeneration of the facets, and you end up doing another procedure because the patient's symptoms recur within
Right.
2 to 3 years afterwards.
Right. So what I'm seeing from this data is that there's different types of stabilizations that create different effects in different age groups. For instance, an older population that has rigid stabilization, this data suggests hypermobility and adjacent level disease pretty quickly after surgery. Whereas maybe younger patients in their 30s, it might not do that, as Dr. Salib just said from his office patient today. So there may be different kinds of stabilization after stenosis decompression that will help us pick the right patients and technique and not force a fusion process on the elderly, which is not necessarily beneficial. Here, there's statistically significant hypermobility starting at 6 months after surgery, and at 4 years in the coflex data, it's even more impressive. And that goes to translation, which creates your adjacent level spondies. So, Mike, you're a neurosurgeon. Foraminal decompression is important. I mean, to decompress the nerve going through the entry, mid, and exit zone of the foramen is the operation. How important is maintenance of foraminal height after using coflex? Is that to you in choosing that device versus another type of stabilization?
Yeah, the foraminal height maintenance is really one of the, if not primary reasons I use the device, because after we do a laminectomy on a patient with stenosis, when they come back, if they come back as a failure, and a fair number will, they typically come back failing by establishing stenosis to the foramen, because we're good at decompressing the central canal, but what we haven't done is stopped that progression of disease. We haven't stopped the up-down collapse of the foramen, the continuance of the degeneration of the disc, and then they get segmental collapse and straightening of the spine, it's not kyphosis, and now your foramen are collapsed. And that's a patient that creates an issue, because the option at that point, since they had a laminectomy already, and now they typically have the foraminal stenosis in addition to back pain or deformity, is to go for a fusion. And one of the worst things as far as patient outcomes in fusion is trying to fix a flat back or a failed back syndrome, is what I'm trying to say, post-laminectomy pain. So it's huge. If we can do our central decompression, decompress the foramen, maintain that foraminal height, and do so sustainably, that's the big selling point for me and what I talk to my patients about.
Right. I think think that's well said. I think that, Sig Bergman just published an article talking about recurrence of stenosis in the Medicare data set, which was essentially the rule of nines, that it fails at 9% per year. And his data set was a 3-year data set. So, you have significant recurrence of stenosis clinically and symptomatically in these patients when their foraminal height and scar and facet degeneration continue. So that's where coflex helps to unload that process and maintain your deep.
I think we lost Hal.
Yeah, I know I lost sound.
Yeah. Hal's phone is blank now. We'll get him back.
Okay. He'll be back.
Yeah, it looks like we lost our moderator, who should be dialing back in again shortly. Sorry for the delay. Just bear with us for a quick minute. Thank you.
While we're waiting, this is Dick Saleb. I have a question for the other panelists. How successful are you at being able to do the Medicare population group who have this diagnosis in your surgical centers?
0 here in Eugene, Oregon.
I don't know if we've done one in the surgery center yet.
Yeah, that's kind of our dilemma as well, and I think this is the policy the Medicare has here is that they won't allow any surgery to be done in ASC. The other problem that we are having is that our 3 major local insurance companies have, as they typically do with any new technology, placed it on a non-covered status, and so they're frequently not covering it.
They're covering it. In fact, it's doing pretty well when we get it into the surgery center. So
yeah.
I think everybody's realizing that, and hopefully this contracting issue will resolve itself favorably. It makes sense economically, and usually if something just doesn't make sense, I think something political is afoot, and I think that's what's going on with the between the hospitals and the payers in our market. So
John,
hospitals.
Thank you for commenting on that. I'm sorry that spontaneously I was kicked off, but we can continue.
All
right,
okay.
Thanks guys for keeping it going. So 1 and 2 levels is approved in this technology, and this is an example of use of 1 level and 2 level coflex in part of the PMA approval process. And the decompression is real. I mean, we've seen great cases from you guys showing the decompression around the device, and it's a real surgery, and it gets really good results because you're doing a good decompression. And it loads the interlaminar line. I think that's really important in this lower left picture where the bone loads. It's not an interspinous process device. So this study is huge because it's evidence-based medicine. It's level 1 evidence talking about spinal stenosis with back pain and instability, and it talks about fusion as the only way to stabilize, and is it the best way in the Medicare population. And also, we looked at cost and charge data, and we also looked at adjacent level data. So there's a lot of information here that helps us about stabilization with patients with spinal stenosis. So I think we've got time for some questions. We've got about 15 minutes, and it's good if we have questions from the audience. We can start to look at those now. I have a couple of statements about that as we're getting queued up for questions. This is one of the best technologies that I've seen that helps surgeon and all the other stakeholders. Most new technology has a long learning curve, a lot of risk, and a lot more cost to the system. this helps every stakeholder in the value tree, including patient, facility, surgeon, family, employer, everybody in the value tree. And really, it's all about time. So if your time to healing is less, you get better quicker. Your facilities are doing patients more efficiently and with better outcomes. Everybody wins the time game. And with more time comes, really better quality of life for everyone. So it really is all about you, the surgeon and the patient, getting the right results. So coflex is really an opportunity for ambulatory surgery settings. It has level 1 evidence. It fits an unmet clinical need. It reduces cost, trauma, and morbidity to the patient. It's on label for how you're going to use it for spinal stenosis. And it improves the values of all the stakeholders in this process. And it is truly a minimally invasive procedure. So everything we said is on label. It's an on-label process. It's approved by the FDA for this. And there's a great opportunity for surgeons and for facilities to really help patients in a controlled environment. So just to start this off, so Dick, let's ask the question about minimally invasive technology and learning curve of doing small incision surgery versus big open surgeries that were traditionally done years ago. What's been your experience as far as the learning curve, how long it takes to be proficient to do small micro incisions? How is that technology teachable in today's market? Now, you've got to remember, surgeons are a lot better trained now than they were. Is it something that they're learning in their training programs, or is it something they have to specifically adjust with the coflex technique?
I think if you're used to only doing minimally invasive surgery through tubes, I think you do have to make an adjustment, because I don't believe that this procedure can be done through a tube. But you can do it through the same, 1.5 to 2 inch, 1.5 incision or inch incision you can make for a microdiscectomy. And, you can, I think the learning curve is very short. It's just a matter of only exposing what you need and making, the key, as the other panelists have said, the key is getting the cauda equina and the nerve roots decompressed. And,
right.
And in the subarticular recess and in the central canal, removing that entire ligamentum flavum and the medial part of the facet joint. We can all do that. We should be able to do that through a fairly small incision, and there's really no additional incision necessary to put in the coflex as opposed to a pedicle screw system. So I think the learning curve is extremely short with this procedure.
Okay. So Mike and Glenn, if you could chime in. So essentially it's a microdisc incision for you.
Yes, correct.
Yeah, so it's really not a huge change in your technique. It's a midline 1.5 inch incision. You really only expose to the middle of each facet on each side. You never have to see the TPs. You never have to strip out and put in a big retractor. So the learning curve for you guys is, as neurosurgeons, is pretty minimal.
Hallett, it's a surgery we're all very familiar with. Even someone who learns from a tube, and when I trained, the tubes had already been in existence, and I learned to do spine through tubes. That's how I did it. And it wasn't until later that I understood the old spine. The point is, we all, no matter if you do tube or not, we understand how to do a one-level laminectomy, and that's really what the surgery is. It's a one-level or segmental laminectomy, for that matter, not even total. And again, I think I said it before, but if the case takes an hour long, 50 minutes is doing your decompression and getting your hemostasis and the lateral gutters afterwards, and then the other 5 to 7 minutes is putting the coflex in and sewing it up, and taking time to sew it right. But it really isn't a divergence at all from what we used to.
Right. Totally agree. So we have a procedure that has evidence-based medicine. It's transferable to an outpatient surgery center. And in fact, most cases in the U.S. right now are being done in outpatient settings for coflex in the U.S. So you've got minimal learning curve, easy technology that's adaptable. It's using keratins and instruments that we already know how to use. It's a small lami tray, not a big pedicle screw fusion set. And it's a set of instruments that are pretty easy to understand and to use. So it sounds like it's an optimal situation for efficiency and reproducibility. Can I get the panelists to agree?
Yes.
Yes.
Agreed.
Agreed perfectly.
Totally. We've seen technologies in the past come through and they're really hard to understand and really hard to teach, and not everybody gets it. I think this is a standard technique that we all were trained on and could do this pretty easily. Okay, so let's go back. Let's go back 20 years. Okay, so we all know that we need to decompress. So when do we talk about decompression alone or decompression with stabilization? And then if we want to stabilize, why do we choose fusion versus motion preservation? So I can remember my chairs saying, you know, decompress them, they all do fine. You know, if they need to come back, they'll come back. And don't do a fusion. But you got to remember, back then, fusions were without instruments. They were onlay bone graft, and we rolled body jackets with plaster. You know, is it changed now? Is it different? Are we now accepting that we need to stabilize these patients, or is simple decompression still the gold standard going forward? So we'll start with John first. What do you think about simple decompression without supporting facet joints and the long-term outcome of that?
Well, I was going to ask, did you train with Galen or Hippocrates or something that's been that long? No. Well, you know, decompression when they have just claudication work pretty well, and that's probably what your staff guys are thinking. But most of the time they have back pain too, and we just accepted the back pain. Or we would do pain management stuff like rhizotomies and things like that. Pretty disappointing. So when we had pedicle screws, and the point was we're going to stop the back pain with stabilizing them, and then also prevent any further collapse, because there's a pretty significant restenosis rate when you just do a decompression. In the old days, when you had the big incisions and took down the ligaments and the spinous process and probably did do some significant damage to adjacent facets, you were setting the patient up for flat back and adjacent level disease. The old ways of putting in screws used to damage the facets at the next level, so it was almost an iatrogenic injury. What was different with minimally invasive is you didn't do any of that stuff from the back anymore. Everything was done with tubular techniques and very minimal disruption to the vascular supply, the nerve supply to the structures. So in our experience, the adjacent level disease could still happen, but we were seeing a lot less of it. But we're also much more cognizant of the sagittal balance, and that's really important. You could restore that with instrumentation, particularly if you combine things with anterior delift type procedures and things. So anyway, it worked, but the problem is it's expensive, it's risky, it's a much more complicated operation that requires a lot more skill and knowledge by the surgeon. The thing now with the coflex, what we've seen in the original study, we see now, because we have follow up everybody like we're doing an FDA trial, and we do digital films, so we look at the motion at the operative segment and the adjacent segments, and we also do 36-inch Scoli films on people, and we're not seeing the kind of things that happen with just decompression alone, with flat backs and restenosis. We're also not seeing the stuff that we used to see with fusions in time. Now, we haven't been doing this, 5-10 years yet, but maybe we'll start seeing that. But anyway, it's a very easy operation that everybody knows how to do, and putting in the implant is really easy as well with so little risk. You don't have the risk of anterior or X-delift type procedures or pedicle screws or all that other stuff. And it's really fast. So, yeah, right now it is preventing the restenosis from what we've seen. I have not seen adjacent level things. Now, what I have seen, anytime you do something, you start to push the indications a little bit. So we've done it on really much more elderly people than we would have done before, and we've seen some fractures of the spinous process, but it hasn't been that big of a problem because it's intralaminar fixation. So we've haven't really revised those either. We just watched them, and they're still doing pretty well. They're walking comfortably, and that, an 80-some-year-old person, that's what they want to do. So
Yeah.
it's a real nice technique that you can do on a huge number of patients that you used to either couldn't help them, or you had some procedure that had some major compromises in what you really intended to do.
Yeah, totally agree. I want to get to, great, John, thank you. I want to get to some of the questions that have been called in. So one question asked about what differentiates coflex from a product like NewMIS of 6. And so, Glenn, a fix, as I understand it, is an interspinous process fusion device. Coflex is motion-preserving non-fusion. They load different bone. Could you describe in your mind what you think the differences are between those two techniques and devices?
Well, you're not, with the coflex, you're trying to maintain the motion at the segment. With the affix, you're trying to eliminate it and join the two spinous processes together. And to be honest with you, I've never put in an affix. That's not one of the techniques that I've used. I understand the concepts. So it's two different things. You want to maintain the motion with coflex. To properly deploy the device, you have to get it down between the intralaminar area, which is much stronger bone than the spinous process themselves. And that's what helps with your axial stabilization and your maintenance of foraminal height.
Right.
And you can see it on the postoperative x-rays, especially on a bigger patient, that the device flexes, and you can do flexion extension films and demonstrate the fact that they still have stable motion at those segments.
Right. So this is the first device that's approved after decompression for spinal stenosis. XDOT never had that labeling. So this is really the first non-fusion motion-preserving device after your decompression for stenosis. Question, one of the participants asked about peer-reviewed publications. So there are two. One is the Journal of Neurosurgery Spine on spondylolisthesis cohort, because spondies were included in this data set, and that's available in print now. The second is the entire PMA, both cohorts, spondy and non-spondy, and that will be in Spine in your mailbox August 13th. So two peer-reviewed publications on PubMed now. That's available. A third comes this fall in JBJS, looking at adverse event adjudication. More to follow next year with QALYs and cost and comparative effectiveness studies and two-level and adjacent level papers. So there's a lot of information that's coming out for you to help with your payers and pre-certifications. Another question was discussing the decompression. So decompression is part of this procedure. This is a direct surgical decompression. So all the decompression codes apply here, that the surgeon does the open surgical decompression. So that is part of the surgeon's technique. And then there's a device code, not specific to coflex, but that's a code that the surgeons can choose with regard to what they want to use for this device insertion. Another is the cost comparison between fusion and for coflex in an outpatient setting. And we had evidence from the PMA study that shows that coflex saves the facility and the system about $10,000 per case over the open fusion technique. And I think that's an important understanding. This process does save money, and it is cost comparative, and it is cost effective. So I think we're almost out of time. I'd like to ask the panelists real quickly if they have any additional comments that they'd like to make. And certainly thank you for your participation in the middle of your workday. We'll go down the list. John, any comments, any thoughts that you want to make sure the participants know from our discussion?
Well, I think most things were covered pretty well in the hour, but what people keep, when we do courses and stuff, they keep thinking it's intraspinous, and it's not. Number one, it's intralaminar. It maintains motion within the physiologic range. Our digitized films were showing between 4, 8, maybe sometimes 9 degrees between flexion and extension, and it's pretty similar to the adjacent levels. So that's really happening, and we're not seeing the adjacent level breaking down yet. You do a real operation to start the case, and then you have to be careful with your decompression. In some courses, I've seen somebody come right in and take the spinous process off or do almost a complete laminectomy. You have to be a little bit more careful with the laminectomy because you have to preserve the pars and the inferior process so you don't destabilize the segment. But you do the surgical decompression. So those are the main things.
Great. Thanks, John. So Mike, any comments real briefly? Anything to add to John's comment?
Just really brief, the slide where you're showing the coflex lives in between the laminectomy without instrumentation and then fusion. I think that's an important slide because I don't consider this to be an alternative to fusion in the majority of cases. I view it as an adjunct to laminectomy, and I just encourage people who are considering it or trying to conceptualize what it is to keep that thought in mind as they're thinking through where to apply it. That's all I wanted to say with that.
Great, thanks. Dr. Salem in Minnesota, any final thoughts?
No, I think everybody, it's all been covered, but I agree. Occasionally, I think if you've got a patient with just, claudicatory symptoms or radicular symptoms in a synovial cyst, you might be able to get by in a decompression, and then you can always, if it does recur, you can come back and do a coflex. But the majority of these people do have back pain, as well as the claudicatory symptoms, and my experience is that this works at least as good and probably better in most cases because the results seem to last.
Yeah, and to that point, the sports study taught us that decompression with patients with back pain doesn't necessarily improve outcomes because their back pain can get worse. Dr. Kuiper, some final closing thoughts.
Nothing much to add other than I would say that I've done about 40 levels of coflex at this point, and it's been a very successful procedure and something that's been greatly beneficial to the patients. Great. Otherwise, nothing else. It's all been well said.
Well, thanks, everyone, and thanks to our participants for hanging in there for the hour and for our technical difficulties. And thanks to Becker's for hosting this and Paradigm for sponsoring this. I think it's a great discussion. It's very timely. It's evidence-based medicine now, improving quality of care and improving patient outcomes through potential ambulatory surgery access. And I think this is a great opportunity for our participants to understand this improvement and how we can help patients get better quicker. So thanks to everyone. Have a good day, and we appreciate your participation.
Thank you, Al. Bye-bye.
Bye.